Dr. Kunza.
All right. Quick plug for the technology services. They also manage our Google stuff. So if anyone has issues logging into Gmail, which pops up every now and again, it would still go to them. Okay, GChat to Slack. I know that there has been communication over our GChat threads. There have been emails sent out, all thanks to Kristen, who has been working tirelessly behind the scenes to coordinate this effort. And what our goal is, yay, Kristen, is to have this be as smooth of a transition as possible. And piggybacking on what we were mentioning earlier with getting to connect with other individuals across Accolade is moving to Slack will allow us to do so. We'll remove a barrier, a big barrier of communication that we have currently because we work through GChat and everybody else is on Slack. So it's time for us to join that line of communication. And let's go to the next slide. And this is going to be happening on the 26th. So this Slack is going to be your new tool for all chat. So speaking with operations, speaking to one another, finding new friends who are in other parts of Accolade. All chat's going to be moved from GChat onto Slack. So there's been a lot of communications out there. One of the main ones to start is make sure your Okta login works. I know the timing of this seems soon, the 26th, but it's kind of, it was very thoughtfully planned out this way, but part of it is we all were doing our compliance training, which required Okta login. And because that can be an issue for a lot of folks, we wanted to couple these together. So most people should have an active and up-to-date Okta login. We can actually see this on the back end as well. So we have contacted folks who maybe aren't up-to-date on their Okta login, but it's going to be important because day of, on the 26th, then logging in to get work done, we'll be needing to turn to Slack to connect with our operations teams, all of us when we're working. So all of our threads that we have on Google and GChat are going to be channels as they're referred to in Slack. So just a terminology difference, but they will still exist in the same way. So certain threads that you're used to participating in are still going to exist there as channels in Slack. And similar, your thread with ops titled your name is going to be the same thing. That's your channel in Slack will be titled your name, and that's how you'll communicate with the operations folks. We're also going to be having a thread for help, for questions, for support, so called the Slack support thread. So that's going to be active and available, and we're also considering how to run office hours to support, and more information to come on that. But again, the purpose is eliminating a big barrier of communication between us and all of Accolade. And also there's a lot of really fun features. I'm happy to say that we had a really great pilot. So this is not a big beta test that's going to happen on the 26th. We had a big pilot and the physicians seemed to really enjoy what we were doing based on everything that was shared. And here with us to share a bit of her experience is our very own Dr. Jessica Saberman, who was instrumental as well in playing with Slack, giving us her insight along with other physicians, but she's willing to share some of her experience with us. If you don't mind, Jessica.
Sure, thank you. Hi, everybody. So I was asked to participate in the pilot, happy to do so. So my experience, just let you know where I was starting off from. I use my Mac notebook when I'm working. I've got one of the large computer screens here in front of me. In my normal daily work, I use Chrome, of course, for FOSSA and for GChat. I like to keep them as two separate windows. For me, it's easier to kind of switch back and forth between my one window for my patient visits and the other one for basically everything else. So that's kind of my normal status. And then when I started with the Slack pilot, there's two ways that we can access Slack. You can definitely set it up as a tab on Chrome, and I tried that. And then you also have an option for basically like a desktop app that you can then keep in like the docking station on your screen, however you like to do that. So I've gone back and forth between both of those. I have tried them a bunch of different ways. I have so far only had to log into Okta the very first time for each of them to use them. Since then, I have logged all the way out, like cold reboots of my desktop, and brought everything back up. Have not ever had to log back into Slack to use them. So really just that one time, and I've been using Slack now for about 3 months. So far that seems to be pretty easy there. And both with Chrome, it's my experience has been it's very similar using the Chrome tab to what the GChat looked like. Although I definitely think there's a lot of features on Slack that are not available on the GChat. With both the Chrome tab and with the app on the desktop for Slack, there's a lot. It seems like there's a lot more ways to personalize what I can see, how I want to organize my threads or channels, and so I like that part of it. And personally, my preference right now is to use the desktop app rather than the Chrome tab. One, I kind of get lost with too many tabs and it gets confusing. And with the app, it's really easy for me to kind of put it to the side and minimize it, but then come back to it when I need it. I also have my notification, and there's a lot of different ways of set up personalized notifications in Slack. And so I've got it set up that my app will bounce a little bit if something with my name on it or on my personal thread comes in, and it will bounce every now and then if I forget to check it, because I do, if I'm talking with a patient, I'm not going to switch over and take a look at that. So it keeps reminding me about that. So that's been helpful. And then I've also played a lot with some of the features in Slack. And one of the things I discovered was an ability to make little videos. And then I made a little video, like a 2-minute introduction of myself. And I posted that onto my personal ops thread or channel on Slack as a way to introduce myself to the team members. And then I shared that also on our Slack migration pilot group. And as a result, a lot of the other people, both ops teams and the docs, did similar stuff. And I thought it was a really fun and cool way for us to get to know each other in a more real way. And I hope that continues as something that we do with each other. For me, of course, getting to know each other just makes communication so much better and meaningful. It just makes the day more fun for me. So that was something that I really enjoyed. Another feature I like on Slack, you have something called Canvas, which is a way that, like for me at least, the way I understand it, that you can create information, you can post things, I've used it now on my ops thread. So I posted that video there, but I've also posted things like my preferences. Anytime I'm asking ops to send a generic email or a generic lab order, always attach my e-cig. I don't want to have to ask for that. I've kind of put a reminder about my normal hours, what time zone I'm in, just something that I kind of want anyone who's new on the ops thread to just kind of look at that just so that they kind of know what my preferences are. So I like that that's an option. So there's a lot of ways that you can personalize it that I've really enjoyed. And then probably for me, the biggest, and also I do mention that there's a way that you can do a huddle really quick on Slack. And I could probably do that in GChat, but it's never worked out so easily. I'm the type of person, like if I'm having a technical issue in the middle of my workday, rather than typing back and forth through GChat and waiting for replies, if I can basically grab somebody, steal them away for a quick 30 seconds to do a quick video and just tell them what the problem is and get a solution, I'd much rather do that. And that's been really easy to do that the few times I've done something like that on Slack. And then really a big thing too is that like Dr. Kunze said, it connects us to the rest of Accolade. And we're kind of our own thing over here as PlushCare, but there really is this whole big world of Accolade going on. And there's so many different conversations, channels going on in there. There's a couple that I've really enjoyed. There's Clinical Corner, there's PlushCare Applause, there's part of Accolade. So there's a whole lot of different things that we can get involved with there as much or as little as we want. So far, I've really been enjoying it. And that's all I've got to add there. Thanks.
Thank you, Jessica. We appreciate you and loved having your input for the pilot and everyone else who's helped. It's been integral and wonderful. Per Kristen's recommendation as well, please everybody just take a look at your email. All details will be there. So if any of that seemed a little bit overwhelming or not familiar, instructions are going to be coming in bite-sized pieces through to your emails.
Wonderful. Thank you, Brittany. And thank you, Jessica. Appreciate it. Great to have that insight. All right, marketing. For many of you, you already know Carlo. I think he's been receiving a lot of your messages on this topic, but he has assumed the role of we're calling it loosely, the marketing liaison. He works closely with the marketing team to help shape what clinical content goes out there to make sure it's accurate and informative and evidence-based and all the things that we want it to be. So thank you, Carlo. Why don't you take over?
All right, sounds good. Let's not move over to the next slide yet. Thank you for the great introduction, James. So thank you all for sending me all of your messages. It's very, very helpful. Before I start, I do have a joke for you guys. So question for you. Why did the marketing liaison bring a ladder to the marketing conference? Because he wanted to take their strategies to the next level. Yeah. All right, cool. So that's my dad joke of the day. We can go ahead and move on to the next slide. Thank you, everyone, for bearing with me. So again, it's been very, very helpful for all of you to send me messages over the past month, both formally and informally. It's been really amazing to see all the feedback. The reason why I made that joke about taking this to the next level is because we all kind of want the same thing for PlushCare, right? We all want the same thing for Accolade, which is to get to the next level. From last year to this year, we've and you guys probably see as well, we've hired so many amazing new physicians, and we want to keep growing. And one of the ways we do that is by marketing. And so the only way to make sure we keep moving forward is to know that any feedback that we have, whether it's formal or informal, just keep sending them over to me. So when I say formal and informal, people have been sending me emails, which is great. Please, please, please keep sending them over to me. And then, as you probably know, I spent a lot of time perusing the GChat thread. So if you have anything on there, that you say, hey, I had a patient that said this thing about marketing or advertising, feel free to add it on there. And if you want to tag me, you can do so as well. As a great segue from what Dr. Coons and Jessica and Dr. Saberman were talking about before, Slack is an amazing way to interact with some people, within the greater PlushCare and Accolade team that we really aren't, exposed to in GChat. So we started a marketing Slack channel, and so I know the big step is to get over to Slack in the first place. So once everyone's kind of gotten settled with that, I'll send an email out, or I'll send a post on the physician thread saying, hey, just want to let you know we have this marketing Slack channel for anyone that wants to know more about what we're doing on a marketing standpoint. So things that are in the future and the horizon. So if there's any comments or feedback that you have on that, that'd be very, very helpful as well. And then it's totally optional. So I know sometimes we get some fatigue with how many threads that we have, or channels that we have in our GChat and so forth. So you do not have to join it, but it's there and it's available and it's open for everyone to see. So it's very, very nice. So you don't have to participate, but you can look into it, whenever you have any questions about anything marketing related. Another thing that we're working on is based on feedback from our physicians, important mass emails. So things like the emails that we sent over for weight loss shortages or our health coaching sunsetting. So we decided that it might not be a bad idea to email our physicians directly as well. So Dr. Holte and I posted on the weight loss forum, and we sent an email out, but we thought maybe if we just added the physicians to the email that we sent over to our patients, it would be great because we're all kind of in the same loop. And so whenever our patients, ask us about an email that they received from PlushCare, we would have gotten it as well. So that's one of the things that we're working on. And then lastly, Forward Bound. So we're continuing to collaborate with our marketing team to make sure that all the content that we put out is medically accurate and evidence-based, as James mentioned. So there's a lot of things that are underway to make sure that continues to happen and to make sure that everything that we do, it gets better in that aspect. But yeah, so those are all the things I have for all of you. Again, I want to say thank you for sending me all the feedback and suggestions that you have. It's really, really helpful for us to know what to look out for. The marketing team is one aspect. It's a group of really amazing individuals, by the way. They're very receptive to all the feedback. So the more you send me, the more I'll be more than happy to share it over to them. But it's just a small group of them plus myself. So if you see anything on, that a patient told you about, please send it my way and I'll be more than happy to investigate. So thank you, everyone. Awesome.
Thanks, Carlo. It's been wonderful having you on that. That's great. All right. Next up, we're going to talk about some data quality specifically related to hypertension, and Brittany has been working on that. And oh, we even refreshed the slide. Okay,
changed the name.
changes.
I changed the name. Okay. Please don't take a nap, everybody. I know. Carlos was awesome, and now we're going to talk about quality metrics, but we are getting a chance to build this from ground up. I think every one of us has worked for organizations. We came in, there were already quality metrics. Sometimes those were used in a punitive way. That's not our intention. Next slide, Talia. Our intention is to see how do we perform compared to others. I think it's about time that we know that, and well, not just me. Not just me. I think we all want to know. But Accolade also wants to see employers who are sponsoring these types of benefits for their employees want to know. And this graph looks really quite crazy. You don't have to squint really hard to read the fine print. I'll explain this. But the good news is so far what we're looking at is looking really good. But this is just the beginning. So this graph is taking a look at hypertension control. We're following roughly the HEDIS specs, the HEDIS metrics. I know they're not clinically the very best, but it's a good basic place to start and gives us a nice way to compare ourselves to other organizations and see how we measure up. The hypertension dashboard is one we've been working on for a long time. And becomes kind of nuanced, and it was difficult to get rolling, but we're starting to really make a lot of headway. So basically what you see here is on the x-axis months since enrollment, so 0 to 8 is what's displayed here. So that's somebody who's in the box 8 has been with us in the hypertension program, so to speak, for 8 months. So that dark blue bar represents individuals who are enrolled in the hypertension program. And for those of you who don't know, there's these programs where we have predefined criteria for individuals to let our EMR essentially know when certain ICD-10 codes are entered that this person is going to be entered into this program based on what they're being treated for and diagnosed with. And there's a few other caveats here. We're looking for people 2 blood pressure measurements, and currently playing with another potential variable here, which is should this person have also an additional ICD-10 code for hypertension? Basically saying, did this person come to us once for maybe a UTI, or are we following them actually for hypertension? So we want to try to be as specific with this group that these are people we're following. We can go to the next slide. So kind of just zooming in here, we're doing really well. So if we look at month 12, so people we have been following for about 12 months, these two numbers added together, so about 70%, those are the people who are considered controlled. And for those of you who know HEDIS, you know that it's controlled kind of loosely, basically less than 140 over 90. We certainly want everybody to do a little bit better than that for the most part. But for those of us, or for those who are following for hypertension and have been with us for about 12 months, it looks like about 70% of those individuals are considered controlled based on this metric. And as you can see on the right side, this is from HEDIS, so some national averages. We're doing really well. So this is just the beginning. We've been looking at ordering images for low back pain. Newsflash, we do really great for that. I think we probably could have predicted that. We're going to be looking at PHQ-9s. We have some issues we're working through with those PHQ-9s, making sure they're accurate. We're going to be taking a look there. A1C, obviously. So I'm happy to have conversations about metrics that you all as physicians want to know how we're doing, because I think from a physician and clinical perspective, we want to use this to drive educational initiatives. We want to use this to drive ways that the product can support us in helping our patients do well with their, whatever they're coming to us for. So chronic disease management or acute issues. So certainly please, you can email me or you can Slack me. Let me know if you have ideas or comments. Happy to have those conversations as we continue to grow this. We don't have an intention of making this part of like a bonus metric. So we're wanting to use these to be better always.
Wonderful. Thanks, Brittany. Appreciate that. Nina.
I was just wondering, with what frequency would you recommend that way? Because sometimes, there's patients who are like, I can tell my depression is so much better because I'm taking care of my plants, or, I don't, I'm sleeping good. And so I don't always go over every single question with them. And so I'm wondering kind of, not only from just a patient care, but just from a data perspective, like how often, if you're seeing people who've been with us for say a year, how often would you expect to have a PHQ-9 in the chart?
I'm glad you asked that. So our goal with this also is to not make our physicians do any more work. Can I get some of those clapping emoji? No, just kidding. We don't want any more work for any physicians. So this is where the product needs to support us. And so PHQ-9 is going to fire automatically for individuals. Currently, it's only annually, which is not quite where we'd like it to be. It's not where it should be if we're going to compare to what HEDIS measures. And so the first step is changing that interval for those that it applies to versus do we want to actually repeat it more for our whole population. So there's still questions. Again, we're sort of previewing this with everybody. This is very new, but with the PHQ-9, there's no pressure on the physician to have to do it. We need to fire the PHQ-9 for the patient to do it prior to the visit. So our physicians are armed with that information going into the visit, knowing what the PHQ might have, what the change might have been over time. If you wanted to ask a PHQ-9, though, based on the HEDIS metrics, we're looking at about a 4-month after treatment is started or after an initial PHQ-9 is completed, and then they have a visit in 4 months. It should be repeated if you want something to compare to, but our goal here is to have the product support us in that effort.
Thank you so much.
That's great. Thank you for saying that, Brittany, too. That is, if you work here, hopefully your belief is that technology can help us be better at our jobs and give better care without more manual work. That's where the technology is supposed to come in, and that's what we're trying to do. Cool. Can we go to the next slide, please? Advancing your own slides, Dr. Erin. Go ahead.
I know. It's me again, guys. Talking about my passion of late, my pet project, which I feel really strongly about, as many of you guys know. And I think I'm really excited. Even today, we, like Brittany said, we've been traveling a lot, but even today I got so many questions about the at-home testing, which in my chat and the physician chat, which I'm really excited about. So really, I know I went over these in the forum a couple weeks ago. It's because we're getting so many questions, I wanted to just go over them again, not in the same amount of detail, and just let you know what's different since we last talked. And then I'm happy to take any questions at the end during the Q&A. So I did add the 3-site testing for PrEP. For whatever reason, it was listing for women, for females, that it is a urine test for the 3-site gonorrhea and chlamydia testing. So I changed it in FACET to reflect what it actually is, which it's going to be vaginal. And also for the, I added a separate male versus female initial PrEP, so gender specific initial PrEP panel, to include a UPREG per guidelines. So that has changed too. Previously, you would just type in at-home testing and look for PrEP. And look for PrEP initial, and there was just one, and now there's 2. I know, Sarah, I'm not thrilled about New York. No, it has to do, it's way above my pay grade, but it really has to do with very state-specific bizarre regulations, and it has to do with the serum creatinine on a DBS card, so the finger stick for serum creatinine. But there are certain, and I'm almost afraid to share this because it may jinx things, but there are certain labs and clinics who can apply for an exemption, which we've done. So our legal team is talking to their legal team, and hopefully soon. Let's see what else is different. Yeah, I like the thumbs up. thanks to Dr. Alicia Goodrum. She asked if we could add, thanks guys, if we could add trichomonas to the vaginitis panel. So I had, I sort of created these other ones. So I love the feedback and I'm happy to do it. I think you're absolutely right, Alicia, that oftentimes that is something missed when we're just doing a typical vaginitis panel. So it doesn't have the other STIs, but there is an STI panel, but it does have trichomonas. Also, please remember there's actually 4 different HPV tests that you can check. Vaginal, anal, urine, and pharyngeal. But please, if it's vaginal, that is cervical cancer screening. So please link it to the cervical cancer screening code, which is the 12.4. That is really, really important for coverage and also for guidelines. And they need to be 30 or older, or insurance will deny those claims. You can certainly order it in a woman and a female younger than 30, a vaginal HPV, but please don't link it to that diagnosis code. There's a specific diagnosis code for screening for HPV. And then you all know about the STI panels. We do have a diabetes panel now too. And coming soon, I just had a meeting this morning, coming soon, the at-home weight management follow-up panels. Marika has been working with me on this as well, and that's something that we're getting really excited about. We can't quite do the initial panel yet because it would not be a good patient experience. It would require too many finger sticks. But I will let you guys know. So the turnaround for, it's a really common question, and thank you for asking it because it's a great one. The turnaround time should be, like the whole thing should take about a week. So by the time, as soon as we put the orders in, it usually takes 1 to 2 days for patients to receive them. Then they have to actually take the kit. So whenever they take it, it has to be sent back in, and that they usually receive it. It says between 1 and 3 days. I've usually seen it pretty quick. Because it's, this is sensitive, so they send them as quickly as possible. I'd say that on average it's 2 days, and then it usually takes about 2 days for us to receive the report. If you ordered them and it's taking longer than that, oh, that's a great question, Brittany. If it's the HPV test gets denied by insurance, it's only $18 out of pocket. So it's really not the worst thing, but still, we'd like for it to be fully covered for them if at all possible. Oh, yes. Also, if you guys are noticing that you ordered tests and you haven't seen the results yet, please reach out to me or Alicia. We will be happy to look it up. I want to know. I want to hear these things. Remember that it really depends on if the patient took it or not. But since they are charged up front for the shipping and kitting fee, which I like to call the convenience fee, they are charged up front for that. But the fee for the actual labs and testing is run through the insurance. But I feel like most people will probably take it because they were charged. But then again, I have a lot of recurring charges on my credit card that I don't really pay attention to. So maybe it won't. But so far, we're seeing a pretty good turnaround. How much is the convenience fee? So I've been asked this question quite a bit today, and I just haven't had a chance to do it yet. I had been listing on here on one of these slides that it's anywhere between 25, maybe it's not here, anywhere between $25 and $59, but I didn't specify the different kits, which I should have in the protocol, even though I have that listed. It's a great question. I don't know why I didn't specify them before. The prep ones are the most expensive. They're $59 just because there's so many different sites that are being tested, so different reagents and things to run and ways to pack it. And then the diabetes panel is $25, which is the lowest. And then most everything else is $39. Let's see, where was I? Keep interrupting myself, which is I think I kind of went over all of this. So let me see. Do we have time for questions now, James, or do you want me to come back to these?
Yeah, we've got questions. Yeah, let's do it.
Okay. Are there questions that I missed in the chat? I tried to catch them while I could.
I think the big one was, does the at-home phrase bring up the entire list of all home tests?
It does sort of. It should. I did notice this morning when I was trying to order a few that it took me typing in at home prep to have all the different prep panels typed up. So this is something perhaps Suniti, I can talk to you about, see if we can maybe talk to the product team and see how we can improve that. But you should, and if you can't find them, I would just type in at home and then the next thing that you're looking for, prep or STI, and it should come up.
Bob,
And
go ahead.
Bob,
Looks like you raised your hand, Bob. I don't know.
Yeah. Do we have any correlation data on the vaginal HPV as far as how it compares to direct cervical
glad you
swab,
asked
pap
that.
smear?
yes, actually, and I have it in the my at-home HPV doc, which I can share with everybody after this. But yes, and it actually has shown that really great data that women who do it from home are more comfortable, can get a good sample in this way. It's not a cervical sample, right? So it's just a vaginal swab, and the data looks really promising.
Is it compared directly in a controlled manner to cervical swabs? And what is the positive predictive value? In other words, what is the chance of, false positive, false negatives, predictive value? Do we know any of that?
I can look into that. I mean, I briefly saw those numbers, but I don't want to tell you specifics without having any of that in front of me. But yes, the results are really good. Also, I really feel like the reason that it's taken off lately is because we're reaching more people, which is why I'm so passionate about this. Is increased access to screen women who otherwise wouldn't have been screened. And we know that these tests are fantastic at picking up high-grade dysplasia. So positives often correlate to CIN 2-3, and so really this, which is why I think so many guidelines are now really clamoring on this, because really it's increased access to screening and finding cervical cancer earlier than otherwise they would have found it.
Is there any difficulty with getting these covered in trans men? Like, do they give us any stink if they're identifying as male? And because
Nope.
it seems like that's a really good population for us to, that those people might not want to go in and get a pap smear.
Correct.
And sometimes we catch them when they're on prep and another thing.
That's correct.
So.
Right. So you just have to indicate the gender at birth, so we know who we're screening, and that's what they specifically ask when we order them. That is just fine. The issue, we had somebody who tried to order one, and unfortunately they were in New York. That was the only issue. It wasn't the fact that we were trying to order it in a transgender male. So yes, that is just fine. Oh yes, Tina, good point. I need to look to edit that. Essentially, we just pick blood for everything, because it doesn't really matter right now because we're entering them in manually. And because a lot of these have multiple sources, multiple sites, you can't select all of those in FASA. So I've just been telling people to select blood for those, if that makes sense.
Another quick question about this. Is there any recommendation that we should be giving about when in the cycle, i.e., patients on the pill, to not do it when they're having a withdrawal bleed, or people who are menstruating when they're menstruating?
Correct. So they'll get an information packet that comes with it and kind of explains that you don't want to be on the heaviest days of your cycle, essentially, kind of like what we tell women when we do in-office pap smears. But light cycles, okay.
Oh, awesome.
So I'll stop talking. Let's see what the next slide is. Oh, it's Q&A. Sorry, I can't see what's next.
More
Okay,
Q&A.
were there
More Q&A.
more Q&A?
thank you, Dr. Saberman, for sharing the ACOG guidelines too. That's great. I think my sense from last time I looked at the data was that this is equivalent in some cases, if not better in some studies, at getting results than even healthcare providers doing the swabs. So it's really well evidenced care that we're doing. And exciting, I think, like if we can show that we improve cervical cancer screening rates in parts of our population or certain subpopulations, like that's sort of groundbreaking, newsworthy data that we could potentially have if we can really get this out there. So really, I'm excited about this effort personally. And all of the efforts that we've discussed today. So I don't want to harp on this one, but I think we're doing really good work, and I'm really proud of the team. So yeah, that's a good question. So we're kind of doing this in a way that's a little bit hacky, right? Like that's why the search doesn't work perfectly, and there's no vaginal specimen, and we're doing it without a lot of technology support and product support. And that's because we want to prove that that physicians will order it and that patients will do the tests and we'll get results, and all those things work before we invest in it. And so I appreciate you all kind of working through the difficulties of explaining the price and finding the orders in the short term, and in the long term, we're going to solve some of these things. One of them is explaining it to patients via marketing and via messaging. Talia, do you have comments there?
Yes, I was just going to say that Sasha and the marketing team reached out while I was in Philadelphia, and they're really, really accelerating the marketing efforts on this. So more news to come. I'm meeting with them next week, but I think they're going to really start sending exactly what you're talking about, more information specifically to, about the cost of the at-home kits and how it works.
Great.
I've been, to make it quicker, Tina, I don't know, I mean, I'm just one person, but I've been telling my existing PrEP patients when I see them, I tell them that I'm going to send them a handout about it. And then so for their next screening, I order the Quest one. Then when they come back and I write their PrEP, I say, okay, for your next screening, you've read over that stuff. Do you want me to do the mail away? And I feel like I've been getting some good traction that way without having to spend a lot of time on it.
That's a very good point. Starting maybe last week or the week before, they started already sending emails to our current PrEP patients that is sent to them after their visit, kind of explaining that, but probably not nearly as good as Kanina's explanation, but we are working on this for sure. Somebody just asked another question.
I think a macro for ops. I think that's a good idea.
Yeah, Alicia has that.
Yeah.
Alicia's building that. Mm-hmm.
And Suniti, to answer your question, I think now would be a great time to talk about brief encounters.
Okay, very good. So y'all probably heard about brief encounters coming soon. They're not launching quite yet, but we're getting there. So I'll just, should I share my screen then?
Yeah, it's Talia if you want to stop sharing. I think Suniti either has a slide or a demo or something. Yeah.
Okay.
We cannot
So I'll
see
just briefly, you can't see?
No.
Let's see. I wonder if I don't have permissions.
There we go. Now I can see.
Okay, can y'all still see?
Yep.
Okay, very good. I wonder if I can't switch to slideshow. Maybe that was the issue. So that's fine. So we're rolling out a new feature on FOSSA called Brief Notes. We're going to change the name to Interval Notes. Basically, the idea is to enhance and streamline the documentation and communication to physicians from everybody else that we work with, operations, nurses, prior authorization team. It would have also been used by the health coaches. And then also just for us to have a way to document things that happen with our patients between visits. A lot of times the cross-cover physicians take care of things for our patients, and then we don't realize what they have done. And we kind of do the same thing next time, creating the same work for them. So this way kind of we'll know, like if we wrote a prescription in a way that wasn't the best for the patient or something, so we can do better next time. It's all about communication. So to create a brief note, it's going to be under the encounter section in the chart. And to create a brief note, you'll just click create brief note. It'll take you to the brief note. You'll choose the reason for your brief note. And basically it's by your job description. Or there's also a section for other. You'll write your note, and then you'll decide where you want to route it. So you can route it to no one. You can route it to the patient's PCP or to the treating physician, which is the cross-cover lingo for the last person who saw the patient. Then you'll sign the note. Once you sign, it'll show up as a brief note, just like our signed encounters show up. And if you want to, you can click on the arrow. Here, I've clicked on the arrow so it shows what was written in my brief note. Once you've created it, it'll show up as a task. If somebody has routed you a brief note, it'll show up in your task list, just like a lab to be reviewed. And it'll have a review page, just like the lab review page. I don't have an example of that here, but we will show you that when it is all good to go. So what we're doing right now, we're not quite ready. We need to set permissions for the non-physician users, make sure they understand the purpose of it, how to use it most effectively. And then we just want to test it thoroughly, because this is the first feature we have that does routing within FOSSA. We want to make sure the display works well, that it's very clear when you have reviewed the information and can done it. And then we want to make sure that the brief notes are showing in the chart as they should. So we're going to test it with a smaller group of users, and then it'll be available to everybody. And we're hoping that we can get rid of a lot of other channels of communication that we're using so that everything can be documented in FOSSA as much as possible. Okay.
Wonderful. Thank you, Suniti. That was great. I'm excited for that to come to fruition.
Suniti, is that going to be available for patients to see?
As much as their encounters are seen, I actually am not sure how much of their encounters they can see, their actual encounters.
This will be part of the medical record. So if they request records from us and sign the release, they will get these as a part of that. It will not be like readily apparent in the app for them to like look at. If that answers your question. And I think that answers Michelle's question as well in the chat. And other non-clinical providers will be able to see it and write them, right? So the ops team or RNs, et cetera, will be able to write these notes. It's sort of the one thing that they can do in the chart.
And we will get an email when you say routed to us. We'll get an email when it happens.
It'll be on your task list, just like labs are. So on your schedule page on the left-hand side, where you have the list of all the things you need to get done and review, it'll be brief notes to review or interval notes to review. And you'll click on it and it'll have a list of the notes that you need to review. And then you can open up each one individually and see what it says.
Great. All right. Any questions about that or other things? Bob?
Yeah. Any traction or anybody else experience this with what I'm calling digital trapdoors, where patients can override certain things? I had a patient today calling from a state that I'm not licensed in, pharmacy in that state, address in that state. And she was referred to me personally by another another one of my patients, but how, once they click on the state, how do they must be a way to bypass that, because she got through and I had to decline the consult because of that. How is that happening? And is there a way to keep them from, to direct them through and not allow that to happen, like with a logic step in the coding where, if the doctor they choose it doesn't have that license, it flags it, for instance, if they bypass that, because that happened today. I just didn't know if that happened to anybody else or whether that's come up before.
Yeah, that's interesting. We have done a fair amount of work on reducing wrong state appointments, and we've gotten it pretty low, but there is still a very small number of them coming through, and it is generally people that are misrepresenting the state that they're in. Whether they choose from the list, I'm in Nebraska, and they happen to be in a different place.
Yeah, but she was
usually knowingly, like they're usually intentionally doing that.
Right. Yeah, and that's happened where you see a different address, different pharmacy, two different states, or they're on vacation or something. But this one, she booked in Colorado, address was Colorado, pharmacy was Colorado, and somehow she still got on my schedule.
Yeah. So if you find a case like that where that says booked in Colorado, and you're not licensed in Colorado, is that correct?
No, no.
That is a technology issue, and you can flag that to Kristen and the physician bugs list.
And this might be for marketing, but I had a patient I'd seen 3 days ago or so, whenever, and we had a follow-up plan, weight loss patient. The very next day, she got what seemed like an automated email encouraging her to have a follow-up visit, and it was signed by me, evidently, and she jumped on, got an appointment, and her labs weren't back. There was no reason for her to have that. So obviously it was a waste. It was a wasted visit. Had to comp it, and it was just, in other words, it impacts our performance metrics in those situations. Plus, it just cuts down on our ability to see patients every 15 minutes. So I don't know if those are going out still or automatically, but she said, "Yeah, I got a message from you to book an appointment." I said, "Well, I didn't send it." And this was like the day or two after I had seen her for a weight loss consultation.
That's definitely on my list to work with Carlo and figuring out the communication between FOSSA and the member experience team, and making it very clear when patients are getting their reminders, what those reminders are saying. And so that's definitely on my list to work on as well. Try to improve that, because we want clarity and we want people to get their reminders in a timely manner when they actually need them, and not get a bunch of extraneous things, because then they're just going to ignore everything. I totally agree with you.
Yeah, and is anybody looking in a granular enough way to see what the instructions were for their follow-up, because that's in the plan, and unless we're looking at every chart, I don't see how we're going to use these automated messages very effectively.
Yeah, I think that's our job, is to, if you have a case like that where you think something funny happened, and we'll look into it. What date did you say in the note? What date did you assign the follow-up? What did the patient see? We can look at all of that on an individual patient basis and then fix whatever's wrong. So definitely send that one to us.
Yeah.
Great. I think that's all the questions. Oh, Shannon.
When we do a Z00, just an annual visit, and the patient's already had them done with their OBGYN that year, or they're going to have them because they don't understand it's the same thing, or we're just not getting, are those getting denied because they can only be billed once, right?
That is correct. Yes. They would get denied, and I believe we just write that off when that happens. I don't think that we I'm pretty sure we don't do anything with that in that particular case.
Okay.
We don't like bill them. Quite sure. Although when you're booking that visit, we do ask, are you sure you have not had an annual visit already this year?
Thank you.
But I can verify that. Allison, to answer your question. Yeah, it's that is strange to have people book and then not show up 3 times. I don't know if they can't reach us or they're confused or I'm not sure. We'll have to dive into that one. And I think you're right, Dr. Saberman. Yes, it's whoever sends that claim in first, I think, is the one who gets paid. Awesome.
I think that may be causing some confusion for the patients because they don't really, when they come to us for a wellness exam, they don't realize what they're getting as opposed to going to see their OBGYN. So I'm trying to make sure I communicate that to them, but this is kind of a different phenomenon to get your wellness through, virtual care. So
Yes, it is. I think that there's definitely some behavior change education that has to happen because you think of those as 2 very different things and not that you can only get one of them. So we'll have to work on improving that language.
Shannon, most of the time, OBGYN, you can see your OBGYN yearly and still have a physical with your primary care doctor. Because they don't necessarily use the 0000 code. They usually don't. They use a different screening code. They should use a different screening code. Now, if they saw their family doctor who also happened to do their PAP, then maybe we're really out of luck. Yeah, we're out of luck on that one. But if they just went to an OBGYN, they typically don't use the same general screening exam code.
There's a well woman exam code, CPT code.
Okay.
Yes.
I was unaware of that.
But I'm sure that there are people out there billing for the wrong one. So
I'm sure. That's why I'm hesitant to say that it's across the board, but typically.
That's true.
Yeah, it's the same as if you'd see your internist and also see your gynecologist both in person in the same year. You get both of those visits paid for.
Yeah, we'll have to look into that with the billing team. Okay, I know we're at time, so appreciate everyone coming and all the conversation. Thank you all for everything that you do, and have a good rest of your day.